Are there some moms out there who are ready to stop? Yes. That's great. That's wonderful. But so many others are not. Now, how do these drugs affect pregnancy? Well, it depends on the class of drugs. I'm mostly going to talk about two different classes of drugs and how it relates to pregnancy. Number one, opiates. Number two, stimulants. So write those two down, opiates, stimulants. And then we'll kind of make a list of each and how they affect pregnancy. We are seeing a few other drugs too. Neurontin, what we're seeing a lot now being abused, and I really think as they tighten down on each kind of drug, it's harder to get pills, harder to get heroin, harder to get then they start using trying other things. I'm hearing a lot about people using dextromethorphan in huge doses, which is in over-the-counter cough medicine. I don't even know what it does, but I'm hearing reports that it's being used in massive amounts. There was a couple babies in NICU last year that they talked about having real issues, and they thought it was from dextromethorphan. So, people are inventive, they'll try anything. But the two classes of drugs are very different in how they act on the baby and how they affect the health of the mom. Okay, number one, opiates. Opiates are things like what? What kind of drugs? Give me some examples of opiates. Hydrocodone, oxycodone, codeine, heroin, fentanyl, all the pain medications, Dilaudid, morphine, all the pain medications that we think of are typically opiates, either synthetic or natural. They all work by binding to pain receptors and relieving pain. They also have a side effect that causes a euphoric effect in a lot of individuals. They also are very addictive, physically and psychologically addictive. So
I was fortunate because I was given those when I had surgery, and they made me sick. I couldn't take it.
Some people they make sick. Some people don't like the way it makes them feel. Some people it makes them nervous. There are people that it makes nervous. And then there are people who it makes them feel like life's a dream. Evidently, from what I've been told. So, everybody's different how they respond to it. So if you're fortunate enough to be somebody who they don't have an effect on you that's positive, then in some ways that's a good thing. So opiates, here's what we worry about with opiates. Number one, we worry about addiction. Certainly, that's a big. Number two, we worry about respiratory depression when too much is taken, right? So we worry about overdose. So when people die of drug overdoses and it's opiate, what do they die of? They stop breathing, right? Respiratory failure. Well, we give them naloxone or Narcan because they just stop breathing. So that is definitely an issue. What we don't worry about or see in pregnancy is teratogenic effects. Opiates are a very old class of drugs. They are very safe in terms of a fetus. Women who've been taking heroin or other opiates throughout their pregnancy do not typically have babies with fetal anomalies. We just don't see it. It doesn't cause them. Thank goodness. Thank goodness we have a lot of anomalies out there. So thank goodness it does not cause fetal anomalies. It doesn't cause a lot of real negative constipation, but the biggest things we worry about are overdose, causing death, and addiction. So with our pregnant patients, then we're worried about the baby being born as physically dependent as mom, right? That's our concern. So then that would mean our goal with pregnant women would be to try to wean them off the opiates if we can, or wean them as low as possible, or get them on something that's more stable. For example, if some woman if she's using heroin during pregnancy, what do you think would be a better way to manage her? Battery's dead. I just left it on all since Monday. I'm sorry, what did you say? Yeah, a something, so better than heroin, which is something that's made on the street. We don't know what we're getting. We don't know how pure it is. We don't know how clean it is. We don't know what's in it. Wouldn't it be better to get them on something that is from a pharmacy, that we can control the dose, we know what they're getting, we know how much they're getting? So yes, we want to transition them from a street drug to a drug we can control. So we use methadone or Suboxone or Subutex in pregnancy. And we will give them that and try to control the dosage. And then if you go to CAMC, to the clinic that they have there, what they do in that clinic is they actually try, while they're pregnant, we're trying to wean them off of the methadone or the Suboxone, whatever they're on. And what they're trying to do is just to wean them until the baby's born. So the day the baby's born, if they say, I'm craving drugs and I'm going to use again, they'll say, well, we'll put you right back on it. We'll put you right back on methadone and Suboxone, whatever you were on, if you want. But they try to wean them for the sake of the baby so the baby is not more dependent. Now, if a woman does not get prenatal care or does not go to CAMC, she goes to other clinics in this area. Most other clinics will not wean them. They'll just stabilize them on a dose and keep them there. There's a lot of controversy about whether it's safe to wean during pregnancy or not. The maternal fetal medicine specialist at CAMC believes it's safe that they wean them. So, we have a lot of patients that come in, some have been weaned, some have not been weaned. So if we've transitioned the mom from, let's say, heroin to Suboxone or methadone, is the baby still going to be more dependent?
Yeah.
Absolutely. We're still going to be dealing with the same issue. So while it's certainly safer for her to be on methadone or Suboxone, because she's not going to overdose, you know what she's getting, she's not using IV drugs, that is certainly safer. It's still going to be the end result of a baby that's dependent on these substances. And we don't know what the long-term effects of that are. I mean, I think we're starting to see some things in schools, and there's a lot of research, but we don't know yet. And I fear to think what we're going to find out when we find out about these babies that have been born addicted to drugs. I'm sure there's got to be some repercussions from that. So those are our main concerns with opiates. Okay. Now let's talk about the other class of drugs that I said were problematic and is stimulants. So what are some examples of stimulants? Methamphetamine, what else? Cocaine, what else? Yeah. Those are the biggies that we think of. Would you say? Want to say something? Adderall, Ritalin, to a lesser degree, but yes, they're stimulants and they are certainly abused. They're certainly. But the biggest ones that we see are methamphetamine and cocaine. And someone asked me, clinical expert said, you still see cocaine? Yeah, we still do. And we used to see it way more than we do now. I never saw methamphetamine years ago, but we saw cocaine a lot. But we still see some cocaine, a good bit. And so what we worry about with that is what happens when you take a stimulant? What does it do to your system? It amps it up, right? So what do you think it does to your blood pressure? Raises it. What do you think it does to your heart rate? Exactly. It raises everything. It amps your whole system up. So methamphetamines are very much more dangerous to the baby than are opiates. We don't see the same amount of withdrawal with methamphetamine, so we don't even have a drug to give them for withdrawal. What we do see is some things that can happen in utero that are very dangerous. If we make the mom's blood pressure jump up really high and her heart rate go up high and everything is really, that means she's vasoconstricted. That's what causes her blood pressure to go up after using cocaine or methamphetamine or whatever stimulant. That high blood pressure, you're going to learn today what high blood pressure does to the placenta. It damages it very significantly. It causes calcification in the placenta, it causes the placenta to essentially die in areas and chunks. If enough of the placenta dies, what do you think is going to happen to the baby? They're going to die. If enough of the placenta dies, it will kill the fetus. In addition, if the blood pressure gets high enough, in the uterus, you have the placenta that's attached to the wall of the uterus. At birth, it very slowly detaches, and then it exits the body. But it should never detach until the baby's born. That's the lifeline for the baby. That's the oxygen supply of the lifeline. If the blood pressure gets high enough, it literally will blow the placenta off the uterine wall from the pressure. And then you have a placenta that's detached from the body. Mom and baby could bleed to death. I have seen moms and babies die from a huge dose of cocaine. They come in, their blood pressure sky high, baby dies, mom dies from an abruption. That's what's called a placental abruption, which we'll talk about later today. So you can see methamphetamines are very dangerous in pregnancy. And it's more when the baby's on the inside than when the baby's on the outside. So if mom and baby survive and the baby's born, they usually do okay. But the concern is while the baby's in utero, the stimulant. So we think about that, opiates, we think more about the problems after the baby's born, where methamphetamine, you think more about problems while the baby's in utero. So also alcohol is an issue as well. We don't know what, if any, amount of alcohol is safe during pregnancy. We just don't know. And it would be not ethical to find out. Let's do a study and see how much alcohol it takes to cause, a tragedic effect or fetal alcohol syndrome. We don't know. So the recommendation is that women drink none. Now, if a woman drinks a glass of wine or two, is it going to damage her baby? Most likely not. But again, we don't know where the level is. At what point do we tell women don't drink anymore? So we recommend no alcohol. What we worry about with alcohol is fetal alcohol syndrome. FAS is the abbreviation for fetal alcohol syndrome. Babies born with fetal alcohol syndrome, you can look it up in your textbook. They have very small heads and certain facial features. They have developmental delays, and it is from excessive alcohol intake during pregnancy. Fetal alcohol syndrome. Smoking during pregnancy is really bad as well. One of the worst things you can do is smoke when you're pregnant. So smoking has similar effects to methamphetamine. Smoking causes vasoconstriction, right? So smoking's bad for everybody. Old people, young people, everybody. Smoking causes vasoconstriction in the vessels. So if you have vasoconstriction in the vessels, what does it do to your blood pressure? It makes it go up. Same sort of effect as methamphetamine. If your blood pressure goes up enough, then you can get calcifications of the placenta. You can get an abruption where the placenta flows off the uterine wall from excessive pressure. So we do see a lot of problems from smoking. We highly recommend not smoking. Also, smoking causes low birth weight in babies. And the reason it causes low birth weight is, again, because the placenta gets damaged. And sometimes it's a low enough level that it's a chronic thing. And so the babies have low birth weight, intrauterine growth restrictions, because it's not bad enough that it causes an abruption, but it's bad enough that it prevents them growing well. So smoking during pregnancy, we can have things like bleeding complications, miscarriage, stillbirth, prematurity, placenta previa, abruption, low birth weight. Sudden infant death syndrome is associated with smokers. West Virginia did a SIDS study years ago. We did it for several years. And one of the biggest things that's associated with SIDS is smoking. You all know what SIDS is? Sudden infant death syndrome. When a baby unexpectedly passes, usually they're found in their crib, and there's no clear explanation of cause of death. We do believe now that it's from CO2. Too much CO2, not enough oxygen, like if the baby has blankets around their face or nose, or babies that are, like, there was a baby in Huntington, I'll never forget this case, where dad was holding on his chest at night on the couch, and the baby fell down between the dad and the couch cushion, and its face was buried in the cushion. It died of SIDS, because just rebreathing CO2, and it just suffocated essentially. So we associate those things with SIDS, and also smoking is associated with SIDS as well. So then, of course, I told you cocaine or other stimulants can cause maternal vasoconstriction and subsequent fetal death or placental abruption. So those are the classes of drugs and what we worry about. Obviously, there's a lot of barriers in getting women into treatment that are using either opiates or amphetamines, whatever class of drugs they may be using. So I remember I told you we have a lot more what we call drop-ins now, which means women who are not getting prenatal care. And they're not getting prenatal care because they're afraid to come in. Because there is a state law now that if you test positive for any substance that you're not prescribed, you get a CPS visit. That's the law in West Virginia. And so they know that. And so they know that, word gets around. So if they have kids at home already, they know their kids are in jeopardy of losing their kids. So what they do is they don't come to the hospital until it's time to have a baby. And it's the whole thing in their mind of, denial. They think they're going to clean themselves up by the time the baby's born. And, because we test every patient now when they come to the hospital. It's routine. It never used to do that, but they do now. And every patient gets a drug test on admission to labor and delivery. I'm sure they think they're going to clean themselves up. And when they test positive, then they get a CPS visit, and then decisions are made as to what will happen to mom and baby. I can tell you there's not enough foster care in West Virginia, not nearly enough. So if the mom is reasonable and agrees to help in a plan, she's probably going to help that baby. It's very frustrating. A lot of the staff feel frustrated a lot. But I do understand a little bit what CPS is. Tell me what you want me to do. Tell me where I can place this baby. Find me a place to put the baby. There is no place to put this baby. So it's sort of like a triage system. I've got to take the worst ones and, saves my few spots for the worst ones, and the rest of them, I have to send back to the mom, so they don't have anywhere to put them. So it's a very kind of sad state of affairs. Also, we still don't have enough rehabilitation facilities for patients who want to go into rehab and get help. We need more of those desperately. There are not enough to go around, so that is an issue. And of course, us as healthcare workers, we can be very judgmental. So that keeps patients from coming in too. When we're judgmental of our patients and critical, we don't usually get very far with them. So a better approach is to be open and honest with your patient, but not judgmental. And I think those of you guys who've been downstairs with Jennifer in the Women's Medicine Center, everybody doesn't get to go, but several of you have been. I think probably she's the best example I've ever seen of somebody who is open and honest with the patient and clear without being judgmental. And there's a way to do that. It can be done. You don't have to, not tell them the truth. You should tell them the truth, but you do not have to judge them and be critical of them and make them feel like they don't have any work, because obviously that's not going to get us the results that we need. So as I said, I already told you about that. CPS is consulted for any mom that with a positive drug test. And if the mom agrees to a plan, a care plan, like, okay, we're going to put you on Suboxone, we're going to put you on methadone, you're going to see a counselor twice a week, or whatever the plan is, if she follows that plan, she gets her baby. As long as she's following the plan of care that's been laid out for her. Whenever you ask someone about their alcohol, drug, even cigarette intake, you can usually assume what they tell you is probably underreported. They usually make it sound better than it is, so they'll usually underreport what they use. So your best, again, non-judgmental, pleasant, but honest attitude is the way to try to get the best, most honest information that you can. And I have your mom must stay on opiates during pregnancy and physically dependent. And again, that's what's been the standard of care in the past. But Dr. Calhoun at CAMC has a program where they've got research that says it's safe to wean women now. Wean them, off of their medicine altogether, so the baby is drug-free when born, and that seems to be working quite well. So they're doing that at CAMC, but not a lot of other places. And we're at the point, I'll be honest with you, we're at the point now somebody uses marijuana, like, we don't have time to worry about that. Not saying it's not an illegal drug, it is, but it's a triage system. If they use marijuana, they're going to fly under the radar. There's just too many other drugs being used that we have more issues with and need to deal with. Are there problems with the baby with marijuana? We don't know. I don't have anything better to say than we don't know. So when there's so many drugs being used, that's the one that falls through the cracks. At birth, if it's any baby, and especially if it's suspected that the baby has been exposed to drugs in utero, we watch babies for signs of withdrawal. And then if we see signs of withdrawal, then they do a scale every so many hours to assess the symptoms, and if the symptoms are bad enough, then they start the baby on usually methadone, what they give babies for an opiate withdrawal. Methadone is what they choose because it's a very long-acting, safe drug. It's very inexpensive, and also it comes in liquid, like real easy just to squirt a little bit inside the baby's mouth, so it's very easy to give to a baby. And then they'll stay in the hospital while they're weaned off methadone. Some of y'all have cared for some of those babies in the nursery, and what were your observations about some of their addictive behaviors that you saw? Anybody? How many of you been in the nursery and seen some? What did you see? Tremors, what else? Anything else?
They want to eat all the time because their stomachs hurt.
Yeah, their stomachs hurt. Any of you see like little red bottoms, diarrhea? A lot of times they'll have to put a light on their bottom because their bottoms are so red. Because one of the symptoms of opiate withdrawal is diarrhea. So adults or children, some of the same symptoms. So they have severe diarrhea, and then they get dehydrated, and their bodies get very red. They're irritable, they don't sleep, insomnia. Again, a common symptom of withdrawal, inability to sleep. So if you think about it, withdrawal symptoms are going to be the opposite of what happens with the drug. When we give patient opiates, what do we know about them getting constipated? They get constipated, right? That's an issue that we have to deal with. So if we withdraw that from somebody who's taking it all the time, they're going to have massive diarrhea. You give it to somebody who makes them sleepy, you take it away, they can't sleep. Again, anorexia is a big sign of withdrawal. They just don't feel like eating. They don't, they may be nauseated. They have hyperactive GI system, hyperactive bowel sounds. So all the symptoms that you get when you give an opiate, you're going to see the opposite symptoms when you take it away. Okay, any questions about that? Any of that? We'll move on to chapter 12 if you don't have questions. I can't believe I left my thing on and now the battery's dead. Left it all one day. Give me the battery. Okay. So this chapter is gestational conditions. The last chapter was pre-gestational conditions, meaning things that the mom had before she was pregnant that we have to deal with during pregnancy. Now we're talking about disorders that did not exist before pregnancy, but now they occur. And a lot of this chapter is going to be preeclampsia and hypertension in pregnancy. That's probably the biggest part of it. Preeclampsia is such a big, common disease. Everybody's heard of it. Many of you know what it is. But we're going to talk a lot about that. We're going to talk about hyperemesis gravidarum, which is when we touched on it in chapter 9, but it's when you have nausea, vomiting in early pregnancy that continues throughout the pregnancy to the point where you lose weight, have electrolyte imbalances, and it can become very severe. Hemorrhagic conditions, there are complications. We're going to talk about that. Includes placenta abruption, placenta previa, surgery during pregnancy, trauma during pregnancy, and then UTIs. Those are things that occur as most of them during pregnancy. All right, let's talk about hypertension first. West Virginia is huge in terms of incidence of preeclampsia. It's very, very common. We have a lot of obesity in West Virginia. We have a lot of preeclampsia in West Virginia, and I'm sure they're kind of somewhat tied together. Overall, in the United States, hypertensive disorders in pregnancy are the most common medical complication reported. Hypertensive complication is the most common medical complication in pregnancy. So therefore, obviously, it's a big contributor to perinatal morbidity and mortality. Which reminds me, before I forget, I told you guys that I made an adjustment on the test. It was one question. And by the way, the average score was, I think, like 85, almost 85, 84.8 or something. So that's very good. There's a question that said, which of these is the best example of mortality? Everybody picked either one, or there were two answers, and everybody picked one or the other, like half and half. So the wrong answer was that the definition of mortality was a complications from childbirth within a given county in a given year. Now, while that is an example of a definition, it is not the definition. What's wrong with that? What's wrong with that answer? Because it's not the right answer. It's too specific. It can be in a state, it can be in a hospital, it can be in a month, it can be in 2 years, So we define the time frame and the location however we want. It's not always in a given county in a given year. So that's what was wrong with it. But it was an example. And the correct answer was complications from pregnancy, childbirth, or complications of childbirth per 1,000 live births. Of course, they both said per 1,000 live births. The person said in a given county in a given year. But because it was an example of mortality, I just counted them both right. So I accepted two answers, basically. So half of you already had it right. The other half of you did not initially get it right, but I went back and counted both answers correct. So if your score went up by 2 points, that's why. If your score did not go up by 2 points, then you already had it right. So that was the only adjustment that I made. Everything else was very straightforward. No real, nothing really confusing. But I just felt like that answer was close enough, and I understood how you could get it confused very easily. But remember, it was just too specific. The definition, you take it and you make it what you want it to be. You pick the number, the time frame, and you pick the location. It's not always a county or a year. Okay, I want to say that before I forgot about it. Okay, so we can have a couple of different kinds of blood pressure problems in pregnancy. So it's going to be important to understand which one we're talking about. You can just have gestational hypertension, high blood pressure in and of itself with nothing else with it. That's called gestational hypertension, or if you see it, sometimes it's called PIH, pregnancy-induced hypertension. Same thing. It's just high blood pressure in pregnancy, no other symptoms, just high blood pressure, nothing else. Now, on the other hand, if you have preeclampsia, then that is a whole collection of symptoms that all have to be present to diagnose it. So we'll talk about the symptoms in just a minute. So preeclampsia is a disorder. If it leads to eclampsia, pre is the before, but eclampsia, what happens? What makes it go from preeclampsia to eclampsia? Anybody know? Seizures. If the patient seizes, they are no longer preeclamptic, they are eclamptic. And then we can have preeclampsia superimposed on chronic hypertension. So everybody knows what chronic hypertension is, right? If you've been diagnosed with high blood pressure, you have chronic hypertension. That's your diagnosis. So can a 25-year-old woman have chronic hypertension? Yes. Is it that common? No, but it can happen. But we can also have a 35-year-old mom, 45-year-old mom. We've got older moms too. The older the mom is, when she gets pregnant, the more likely she is to have underlying hypertension. Young people can have it too, though. I've seen young women have it, especially when associated with obesity. So chronic hypertension is something that they already would have had. So they can have that, and then we can have preeclampsia superimposed on top of it. So that's really like a double whammy. Okay, so let's talk about that. Chronic hypertension. This is the one thing that would be present before pregnancy. So even though this whole chapter is pregnancy-induced conditions, we're going to talk about the effect of chronic hypertension, what happens when you get pregnant and you have it. So chronic hypertension is defined as to being present before pregnancy or diagnosed before 20 weeks of gestation. So we believe that before 20 weeks of gestation, blood pressure, you cannot have pregnancy-induced blood pressure issues if you're less than 20 weeks. We might have a patient who never goes to the doctor, and she may already have chronic hypertension. It's just not diagnosed because she doesn't go. A lot of young people don't go to the doctor, and they have high blood pressure. They may not even know it. So if a patient goes for her first prenatal visit, she's 10 weeks pregnant, her blood pressure is 150/98. She probably has chronic hypertension, and she just didn't know it. She was never diagnosed. So we assume that anybody who who we discover their blood pressure is elevated and it's below 20 weeks, we assume they had pregnancy blood. We assume that they had blood pressure problems before pregnancy. What I'm trying to say, because before 20 weeks you cannot have preeclampsia. You cannot have preeclampsia before you're 20 weeks pregnant. It does not exist by definition. So chronic hypertension is anybody who had diagnosed high blood pressure before pregnancy, or it's diagnosed in the first 20 weeks of pregnancy, meaning we suspect they had it all along. They just didn't know. Everybody understand that? Good. So if you have chronic hypertension, then remember I said you can have chronic hypertension with superimposed preeclampsia. Well, how do we know? How do we know that it is now preeclampsia? Well, there's the addition of some very important symptoms that tell us that. So, and we'll talk about the symptoms in just a minute. So remember I said you can have gestational hypertension, which is the onset of hypertension without the other symptoms of preeclampsia after the 20th week of pregnancy, and then preeclampsia. So you either have chronic hypertension, meaning you had it before you were pregnant, or you have gestational hypertension, meaning it develops during pregnancy, but it is not preeclampsia by definition, or you can have preeclampsia. Preeclampsia is a pregnancy-specific syndrome. You must be pregnant to get it. It develops after 20 weeks of gestation, and it's a vasospastic disorder. So why is your blood pressure high? Because you have vasospasm. That's a little bit different than chronic hypertension in as far as the pathophysiology. The spasm of the vessels is what's causing the problem here. And so if you think about it, spasms of the vessels also are going to affect oxygenation and potentially in mom and baby. Preeclampsia can be mild or it can be severe. It can be so mild we don't diagnose it until the patient's full term. They come in at their last prenatal visit, they're 40 weeks, and today their blood pressure's up. And we test everything else, they have preeclampsia. If they made it that long, they're probably going to be fine. if they're 25 weeks and they're diagnosed with preeclampsia, they're in a rough spot. What are you going to do for the next 15 weeks?
Nothing.
If you make it if you make it to 40 weeks. Usually if they're diagnosed that early, we do start to put them on bed rest immediately until they don't make it to 40 weeks. They'll get sicker and sicker. All right, so let's talk about, okay, then eclampsia last is a patient who had preeclampsia becomes, starts to have seizures or goes into a coma. Usually the coma comes after seizures. Seizure activity or coma in a woman diagnosed with preeclampsia. And this means she does not have any other pre-existing seizure disorder that we could blame it on. So if someone has a seizure disorder and they have a seizure, it really muddies the water. What's going on with her? Is it a seizure? Is it preeclampsia? What is it? So, that's a tough one. Eclamptic seizures can occur anytime in pregnancy after diagnosis of preeclampsia, but they're most likely to occur at labor, delivery, and afterwards. They're most likely to occur during labor and delivery and after birth, interestingly enough. I've seen patients come back as long as 10 days after birth, having seized at home, especially if they're diagnosed with preeclampsia got missed. We had a patient, or a student rather, a couple semesters ago, that we were still doing Zoom classes at home because I can remember just being on the Zoom. She was telling us about 2 days after she had the baby, she got up in the morning, she had her baby, she was ready to go home, so she felt great. And the doctor came in and checked her blood pressure and said, well, you're not going anywhere, your blood pressure's sky high. So they started looking, digging into it. She had preeclampsia, severe preeclampsia. She was in the hospital for days. It was not diagnosed until 2 days after birth. And as I said, I've seen patients come in an ambulance because they had a seizure at home and a baby 8 days ago. It can happen.
What's the mortality rate?
If they seize, it's high. It's about I don't know that I can give you a number because I don't know that I remember, but it's somewhere like upwards of 30%. And I'm not sure about that because I've read it, but I don't remember for sure. If they seize. They don't seize, the mortality rate is much lower. Seizures really make things more complicated. Okay, so for preeclampsia, signs and symptoms develop only during pregnancy and disappear after birth within 6 weeks after birth. I'm not saying immediately after birth, because remember what I just said, but within 6 weeks after birth, the symptoms will disappear. There is only one cure for preeclampsia. What is the cure? Have the baby. Get the baby out. That is the only cure. Everything else is just prolonging the inevitable. Yes, we put them in bed rest. Yes, we give them this medication. Yes, we give them that medication. It's only prolonging the inevitable to try to get the baby to be more mature. So if a patient's 40 weeks and develops symptoms of preeclampsia, what do we need to do? They're 40 weeks, get the baby out. If they're 37 weeks, get the baby out. The only reason to wait is if the patient's preterm. And then we have to look at how serious is the preeclampsia. It's, again, risk-benefit. Should we try to keep the baby in a little longer? Is it safe to do that to get more fetal growth? Or do we need to look at the baby? Patient's 25 weeks, and we'd like to get a little more growth if we can. So we'll talk about that in a minute. Okay, risk factors. You will find, if you haven't already, that I'm really big on risk factors for diseases. If you don't know what makes you, if you're at risk for something, you don't know to be watching for it. So what are risk factors for preeclampsia? Family history, multifetal pregnancy, twins, triplets, African American race, obesity, age. Younger than 19, older than 40. I can't explain why a teenager gets it and a 45-year-old woman gets it, but that's the categories. Under 19 and over 40, and I've seen it time and time again. Older women and younger women. So I would take note of these risk factors. Family history, multifetal pregnancy, African American race, obesity, age. Very young, very old. All right. So how do we know they have preeclampsia? Remember I said it's more than just blood pressure. PRE, preeclampsia. P, proteinuria. They have protein in their urine. R, rising blood pressure. E, edema. The pre for preeclampsia. Proteinuria, rising blood pressure, edema. All three must be present for diagnosis.
The book says that they were reevaluating
I know that. They're getting rid of edema. But I will tell you in clinical practice, edema is still considered. So I know your book does say that. I don't know what to think about that because I don't see any change in practice. So this is the one time I will take exception to the book. I will say we're going to go with the PRE and we're going to stick with edema. But yes, I know your book does say that. Maybe we'll get to that point sometime, but in practice, and I've seen this in more than one hospital, they are still looking at edema. So what they're saying, I think what they're saying is all women have edema.
Right. That's what the book says.
Yes. So how do you know that edema is just specific for preeclampsia because all women have it?
Right.
So.
But I think, I agree with you. I think it's still something you want to make note of, certainly.
And what you see with preeclampsia, like all women will have hand and feet edema. But preeclamptics, what I see with preeclamptics, I see their nose is swollen, their lips are swollen, their whole sacrum, if they're laying in bed, will just be total edema from where they're laying in dependent edema. So it's significant and severe in preeclampsia, where I just see, in practice, I see mild edema in most pregnant women. So, this is the time I'm going to take exception and say we're going to stick with the edema for now because that's what you're going to see in clinical practice. The triad, proteinuria, rising blood pressure, and edema. Now, what else? So those are the things you have to have for diagnosis. They must be present for diagnosis. So there are other things that may be present and will indicate worsening disease. For example, you may see pitting edema. You don't have to, but you may see pitting edema. It may be significant, and you often will see significant worsening edema. Deep tendon reflexes. How do you check your deep tendon reflexes? So you hit your, like your patella or you find an area. What are we looking for? We're looking for the reflex to kind of jump, right? We're looking for a reflex response. If I sit down and I take the reflex hammer to my patella reflex there, my leg jumps. You've been to the doctor and they check your reflexes. So normally you should see like a moderate, kind of just a response like that. That's called 2+. Just like when we look at edema, reflexes are 1+, 2+, 3+, 4+. 2+ is normal. So, for reflexes, 2+, normal. 3+ is going to be brisk. 4+, very brisk. 1+, decrease, and then absent. So, what you see in preeclampsia is worsening, brisk and very brisk. And then you can also see something called clonus. So when you do that reflex, if I sit down, if you show you better, sit down. We use a reflex hammer, and we do a reflex, and I hit my patellar reflex, and it just goes like that. So if it goes like that, does it multiple times, that's called clonus. When you hit the reflex hammer, you get more than one response. Like it'll go, then maybe a couple extra. One extra beat is 1 beat of clonus. 2 times is 2 beats of clonus. 3 times, 3 beats of clonus. So when you get an extra response, that's called clonus. That's bad. That's really bad. So what we see with preeclampsia is brisk reflexes. The worse the patient is, excuse me. The worse the patient is, the more brisk reflexes we see. If we see clonus, we don't worry. So that's a sign. We're going to talk about why that's a sign of preeclampsia in just a minute. Then also, if we look at the labs, of course, proteinuria, you can check it one of 2 ways. You can do a little dip of the urine and get trace or 1+, 2+ of urine. 1+ or more is considered significant on a dipstick. Or if you do a 24-hour urine specimen, greater than 300 milligrams of protein in a 24-hour urine is indicative of preeclampsia. So we can dipstick it, and if it's greater than 1+, that's significant. Or if we send it off for 24-hour urine, then the result is greater than 300 milligrams. So labs, we may see elevated liver enzymes. Not always, but we may, in worsening cases. We may see low platelet counts. But what we must see is the PRE. That's what we must see for diagnosis. The other things are signs of worsening condition. What about the blood pressure? Now, high does the blood pressure have to be? It says rising blood pressure, but what does that mean? Okay. Blood pressure greater than 140/90 times 2 within a 6-hour period. So we don't just take one blood pressure, 160/100, we don't panic. We check it twice within a 6-hour period. If it's 160/90 or higher, that's considered severe preeclampsia. If they have all, the proteinuria and the edema, their blood pressure is higher than 160/90, that's considered severe. And remember I said for proteinuria, it's 1 plus little dipstick, or your 24-hour urine that has 300 milligrams in it, either or. Generalized edema. Usually with preeclampsia, we don't just see hand and feet edema, we see generalized edema everywhere. So all those things must be present. So remember I told you about checking a pregnant woman's blood pressure. Sitting, lying, standing are not appropriate for pregnant women. So for pregnant women, remember, we check blood pressure. We can check it sitting up, and if it's elevated, we'll put them on their left side and check it again. Remember, if you put them on their left side, you check them in the upper arm. You're going to get an artificially elevated blood pressure. Okay. So a few things about preeclampsia. It progresses on a continuum from mild to severe. So it may be mild, and again, after 40 weeks pregnant, when they get it, it might stay mild, and they have the baby and all is well. If the more early you are in pregnancy when you get it, the more severe it tends to be. So if you make it to late pregnancy before you get sick, you're apt to do fine. If you get it early in pregnancy, you are really probably going to be in trouble. You're going to have a preterm birth and you're going to be very sick. Preeclampsia does cause disruptions in placental perfusion because of the high blood pressure. Remember, the blood pressure is high. What do we know about placentas and high blood pressure? Placentas don't like high blood pressure. It calcifies the placenta. So are we likely to see a baby of a mom with preeclampsia have intrauterine growth restriction or IUGR? Absolutely. That might be one of the indications for delivery. They may say, well, she's preeclamptic, we've got her stabilized, but her baby has been severely diagnosed with IUGR by ultrasound. Maybe the baby would be better off on the outside if we're having significant problems with fetal growth. And remember, there's generalized vasospasm, which causes some decreased organ perfusion, which we'll talk about in just a minute. And there's no known real cause of preeclampsia. We know risk factors, but we don't really know what brings it on exactly. That's just an example of pitting edema. You've never seen that before. And then again, if you want to 1 plus 2 plus 3 plus 4 plus pitting edema, that's how you measure it. I mean, that's just FYI. Now, this is the slide I wanted to linger on just a little bit, because what this slide does is came from your textbook, and it talks about the symptoms and what's causing it over here. For example, if we look at the hypertension, the uteroplacental spasm, glomerular or kidney issues, cortical brain spasm, retina spasm, liver ischemia, it all comes from the vasospasm. So remember, this disease is a disease of vasospasm. So vasospasm causes this, which symptomatically then causes this. So the uteroplacental spasm causes IUGR. The cortical brain spasm, that's where we get the headaches, the hyperreflexia, the seizure activity. So you can look at each thing that's happening and see what happens and what symptoms it causes. I love this slide because it really breaks down what's going on in the body and what it causes. So I don't want you to memorize this, but I do want you to understand why a patient is apt to have hyperreflexia and seizures. You know, hyperreflexia and seizures are very closely tied to each other. People that have brisk reflexes are usually, closer, have a lower seizure threshold, closer to having a seizure. When you are alcoholic in DTs, what happens when you're in DTs? You're at risk of seizure, right? Those patients have very brisk reflexes. That's why they treat them with the same medication we use for preeclampsia. So we're worried about them. They're having issues from the alcoholism that cause seizures. Hyperreflexia. Same thing here. Intravascular coagulation. We can have some coagulation issues from preeclampsia in its most severe case. So a complication of preeclampsia, called HELLP syndrome, causes platelet issues, hemolysis of red blood cells, low platelet count, then the permeability and capillary leakage from the vessels. is what causes the proteinuria and generalized edema in the body. So that tells you what's going on over here, what body system it affects, and then what the symptomology is from that. So I just think it's very helpful in understanding the disease a little better. Okay, there's a variant of preeclampsia called HELLP syndrome. About 10% of all cases of preeclampsia develop into HELLP syndrome. That's it. It doesn't have to develop into HELLP syndrome, but it can develop into HELLP syndrome. This is a type of preeclampsia that is very severe. And for HELLP syndrome, you have to, the HELP comes from the symptoms you have to have. So first you gotta have preeclampsia, that's number one. Once you've got that, if you have HELLP syndrome, you have hemolysis, elevated liver enzymes, and low platelets. So in this type of preeclampsia, the liver enzymes are affected, the platelets are affected. So if we went back to that previous slide, we could see down here, this is where the intravascular coagulation is involved with HELLP syndrome. So you don't have to have every one of these symptoms to have HELLP syndrome, you just have to have those three things. But these are all the things that can happen, may happen in worsening cases, don't have to all happen. So HELLP syndrome, hemolysis, elevated liver enzymes, low platelets. Hemolysis of red blood cells, and that means breakdown of red blood cells. When you break down red blood cells, the liver has to kind of chew them up, metabolize them, spit them out, and get rid of them, and then the liver starts getting into trouble, not being able to manage that. So hemolysis, elevated liver function, low platelet count. I've seen patients with HELLP syndrome have a platelet count of like 10,000 or lower. I had a friend once, and of course this would be somebody who was a friend, who had married someone who was Jehovah's Witness, and she really wasn't, he was, and his family was, and as you know, Jehovah's Witness did not receive blood products. So she had HELLP syndrome, her platelet counts were so low that they needed to deliver the baby, and they were afraid she was under platelet counts was below 20,000. And it was a huge ordeal for, her family, and his family trying to force her, not to take blood products and platelets, and she wanted them, and, so that can become an issue if you happen to be dealing with a, person who does not receive, blood products for any reason. But, that's when, that she ended up being okay, but she was in danger of death, very much so. And she ended up taking platelets so she could have a C-section and ended up being okay. And I don't know what would happen if she hadn't. I'm not sure what would happen because the platelets were so low, they didn't feel comfortable with a C-section even. So the platelet count just gets lower and lower and lower. And I told some of you guys yesterday, and I'll tell you guys today, anesthesia even won't even put an epidural or spinal in if your platelets are below 100,000 because of the risk of damaging around the site of the epidural or spinal. So, these patients have to be put to sleep for a C-section as well. The treatment is to give them platelets, watch their liver function. I saw one patient once, years ago, this is back at Memorial, how long ago it's been, died of a liver rupture for preeclampsia. Your liver ruptures. Before we could figure out what was wrong with her, she died. And as it turned out, on autopsy, she had a liver rupture from severe preeclampsia and HELLP syndrome.
How quick does that happen? Did they miss some signs and symptoms, or that just
Well, they knew she had preeclampsia. They did know that, but they had not, they had delivered the baby. They had delivered the baby. So they delivered the baby, but she was still really sick. And I don't know, I can't remember a lot of the details, so I don't know if they missed something, but they knew she had preeclampsia, but once her liver ruptured, she was dead in 15 minutes.
What percentage of those who die is a result of the liver?
Well, it would either be from low platelets and you hemorrhage from another cause and you just hemorrhage. Now, it's very rare to have. Like, I don't know the statistics, but I can tell you that in all my years of practice, I've seen one liver rupture, only one. So it's not common at all.
It's usually hemorrhage.
It's usually hemorrhage related to platelets, low platelets and stuff. So this patient who had a liver rupture, she also had low platelets, so it didn't help anything that she had no platelets. And then, your liver is so vascular if it ruptures. I mean, you don't have much hope. In 1987, whenever it was, before we moved to women and children, she certainly didn't have a lot of hope. So she did pass away. But nowadays, we don't usually let it get to this point because we deliver the baby and try to get the patient turned around, and we're much more aggressive, and so I think we're more effective in treating it. But just remember that HELLP syndrome happens about 10% of the time of the patients that have severe preeclampsia. About 10% of them will get HELLP. That's it. The rest of them will not. So these are specific things that you see with HELLP syndrome that is a severe variant of preeclampsia. That may or may not occur with preeclampsia patients. So let's finish this up and then we'll take a break. So HELLP syndrome, let's see. Everything else is about the same. Now this upper right quadrant pain, that's significant because that's your liver. So if you have a patient with preeclampsia and they start saying, I'm having what we call epigastric pain, that should be a ding, ding, ding. That's really bad because if your liver's hurting, that means, there's something going on in your liver. That means you got a big problem. And it's probably related to, severe preeclampsia and HELLP syndrome when we're worried about the liver. So HELLP syndrome patients have an associated increased risk for pulmonary edema, renal failure, liver hemorrhage or failure, DIC, disseminated intravascular coagulation, placental abruption, respiratory distress, sepsis, stroke, fetal maternal death. So it's a bad thing to have. There's just so many systems that are affected by that. So we want to be really vigilant with our patients with HELLP syndrome. So we're going to need to get them delivered as quickly as we can, but you can't just run to the OR where a patient has a platelet count of 250,000. So you guys know that the normal platelet count is what? You should know. If you don't know, you need to know. What is normal platelet count?
150.
Yeah, it depends on your lab, but most of the time it's going to be anywhere from 140 to 150,000 to 450,000. CAMC, I believe, is 150 to 450 or 140 to 450, something in that range. So in that vicinity. I can tell you that below 100,000 is when we start worrying. And, if it drops below 140, that's significant. It should not be below that. But below 100, we start worrying. If you have a platelet count that's below 60,000 or 60, a lot of times if it's, we'll call it 60, or you're saying our platelets are 100, or platelets, we mean 100,000. That's what that means on report. So if your platelets are below 60 or 60,000, you are at risk for hemorrhaging from a minor trauma, like an IV stick, or brushing your teeth, or something like that. You're below 60, you're at risk of hemorrhaging from something minor like that. You get your platelets below 20,000, you're at risk from hemorrhaging from nothing, from sitting there, being alive. So you can, less than 20, or 20,000, when I think 20 or 50,000 is what actually it means. So below 60, you're at risk of hemorrhaging from a minor trauma, brushing your teeth, IV stick, just something small. Below 20, you're at risk of hemorrhaging from nothing, from just being alive. Roll over in the bed and touch the side rail. That's when you have a bruise from here to here. So it's life-threatening when you get these platelets get to 20,000. You have a brain hemorrhage, you can have a hemorrhage anywhere. So that's not just OB, that's just across the board. That's a fact across the board. So this is a picture of assessing reflexes and all the different places you can assess reflexes. If your patient's ambulatory, but the patellar reflex is by far the easiest one to elicit, but you get really good at it when your patient's on bed rest. We usually do the brachial ones when our patients are on bed rest, or sometimes at the Achilles tendon. But those are all places where you can assess your patient's reflexes, and you have to be able to hit it in the right spot, and then you look for the response. Preeclamptics are easy because you get anywhere in the vicinity, and they will move, they will jump, because their reflexes are so brisk that they're easy to stimulate. So they can become very easy to elicit. And remember, if it has more than one, if the puberty moves more than one, that's a beat of clonus, and that's bad. So, it is a subjective thing to say, is it 1 plus 2 plus 3 plus 4 plus? Yes, it's very subjective. So you have to see some normal reflexes to understand what 2 plus is. Once you've seen some, then you understand, okay, that's 3 plus. So it's a very subjective report. Because, again, you have to see it, and then you have to think that, well, that's more than the last time. It can be hard and subjective. Okay, so we're going to talk about how to manage preeclampsia. So go ahead and take a break before we start on that. Everybody's feeling. Then we'll talk about management.